So pancreatic ductal adenocarcinoma, or PDAC, is the most lethal of the major cancers. And although surgical resection offers the best outcome for these patients, most patients aren't candidates, allowing focused ultrasound to have great potential in this field. As you can see in this MR image of a mouse, the relative size of the pancreas compared to the surrounding organs is very small in a mouse, only 2 millimeters in the pancreatic head. So containing our heat to a small focal zone is incredibly important in our study. In this study, we use KPC cells orthotopically implanted into a syngeneic line. The Tuvison lab at Cold Spring Harbor has demonstrated that the culture conditions of KPC cells is incredibly important to how they behave in vitro. When they're cultured as an organoid model in a 3D fashion, they're able to retain their dense stromal architecture, which is characteristic of how they behave in a human. So here we injected cells, or the 2D monolayer cells, into these mice, and by day 10, we're able to see the formation of two distinct tumors, one within the pancreas and one that is invaded rapidly into the surgical site. We see the same at day 10. By day 16, there's metastases, MR visible in the spleen. Histological confirmation shows ductal formation similar to that in humans, and also aggressive invasion into the spleen, liver, and pancreas. We used FDG PET to further enhance our visualization of these tumors. By day 10, we see a large uptake of FDG within the tumor that infiltrated the surgical site. By day 14, this has subsided, but we see a great enhancement of visualization around the tumor within the actual pancreas. And quantitatively, we're able to distinguish the maximum uptake of FDG within the tumor in the pancreas from a wild-type mouse, and to establish. And then we also ran a sham procedure to see how this surgery affects the FDG uptake in this invasive region, and we see that although there is a large FDG uptake at a short time point, this subsides at a later time point. Further, we had assessed our current system with a 7T Bruker biospec and image-guided therapy system to ablate our pancreatic tumors. So we're able to retain a small focal volume around the size of a grain of rice, ablating at a relatively high frequency, and we could ablate in a single spot or even in a scanned circular trajectory to cover a larger volume. We confirm this histologically. 2 hours after a circular ablation, we're able to see necrosis, red cell extravasation, and loss of cell-cell adhesion. A full day after a single point ablation, we see the same effects, in addition to an inflammatory reaction and tissue remodeling. In the future, we hope to use novel squalene-gemcitabine nanoparticles concurrently with this with focused ultrasound ablation. Gemcitabine is a commonly prescribed chemotherapeutic for PDAC. By conjugating it to a cholesterol precursor based off of the work done in France by the Couvreur laboratory, we can turn this molecule into an amphipathic structure that will naturally form nanoassemblies. These nanoassemblies are capable of a more effective kill of KPC cells in vitro than gemcitabine alone once you get to higher concentrations. Importantly, our lab has shown that we can get to these higher concentrations when we leverage the powers of focused ultrasound. And the image at the bottom, it's a bilateral breast tumors in mice. One tumor was ablated, and then copper-64 labeled liposomes were circulated throughout. After just 3 hours, you see a maximum accumulation of these liposomes, leading to a 50% drug enhancement in the ablated rim. Importantly, this effect is long-lasting, and you can still see an enhanced accumulation even after 2 days. In conclusion, our current model parameters have led to a rapid disease progression and an aggressively invasive model. Further, we're going to develop the model comparing the 2D to the 3D cell culture conditions to compare the stroma and the disease progression. We can also compare different cell lines using a slightly less aggressive model of KC cell lines. In the future, we also plan to enhance the delivery of nanotherapeutics similarly to that breast cancer model using our squalene-gemcitabine nanoparticles. Additionally, Abraxane is already a clinically approved nanotherapeutic for the treatment of PDAC, meaning that altering its delivery could have significant clinical impacts for these patients. And furthermore, in the future, we do hope to pair this model with immunotherapies in order to launch a lasting and systemic effect in this incredibly invasive disease. Thank you to my funding sources.
Questions from the audience?
I have a question. Very, very nice presentation. Have you done any survival studies to look at using FDG PET to monitor the response to therapy? I think that's a big clinical question in terms of how do we monitor the response to HIFU ablation and whether or not we could use PET. And you did some nice studies to demonstrate that its initial response, but have you done any survival studies and compared it with histology to see whether or not we can use PET to assess response to therapy?
Not yet. Currently, we used it just to establish the model, but in the future, we could assess our therapies with it.
Yeah, and that would be an extremely useful study.